Welcome to today's CMHC webinar, Looming Cardiometabolic Crisis, a conversation about race. I'm Dr. Ferdinand, the Gerald S. Berenson Endowed Chair in Preventive Cardiology, the co-chair of the ABC CME Committee, and a member of the CMHC Steering Committee. I'm Professor of Medicine at the Tulane University School of Medicine in New Orleans. And first, a few housekeeping notes. Today's webinar is a conversation with key experts and stakeholders and personal friends of mine to discuss some of the challenges and disparities in cardiometabolic health and outcomes in racial and ethnic populations. This is a conversation. This is not a lecture. We're not giving data per se. It's not just a recitation of disparities, but what we can do going forward to reduce and eliminate these disparities. If you need to have data and background, we do have resources available. They'll be emailed to you. And as a registrant of this webinar, they'll also be posted in the chat. You'll be able to see some of the resources. All of the speakers today have been published in peer-reviewed literature on some of the items on which they're going to discuss. Now, there's no CME for this, but hopefully learning will take place. And we're doing it now because of two things. Number one, this is Black History Month, and we want to celebrate some of the victories and success that Black physicians, Black health providers have seen over the last several decades and some of the challenges going forward. However, it is also Women's History Month, March 1st, which is less than a week away. And they're going to also celebrate what young women will provide in cardiovascular medicine going forward. As you know, not only have racial and ethnic minorities been underrepresented, but women have been underrepresented in cardiovascular medicine. And the theme of Women's History Month is providing healing, promoting hope. So we're doing this because health life expectancy has improved over the last century for all Americans, but there remain disparities. There is a white-Black mortality gap, mainly driven by cardiovascular and cardiometabolic conditions. African Americans have higher rates of hypertension, diabetes, obesity, premature myocardial infarction, stroke, chronic kidney disease, end-stage renal disease, and early death. The reasons for these are complex, and although our title mentions race, we all know that race is really not a true genetic or biologic construct. It's a social construct. And for the most part, these reasons are reflections of the social determinants of health, where people work, live, play, and pray. The conditions, the economic environment, food deserts, educational disadvantagement that affects the health of the individual and their communities. So taking together these social determinants of health with the increasing risk of hypertension, diabetes, obesity that we see in the population will cause what I call a tsunami, a wave that may overtake the healthcare delivery system. So what we're going to hear today are a discussion of how not only can we identify these disparities, more importantly, how CMHC, along with its mission of addressing cardiometabolic risk across all populations, for the February Black History Month, and I've added for Women's History Month coming up next week, how we can address and reverse these. You're going to hear in the following order. They're all geographically diverse too. I'm a kind of mad scientist, and I wanted my friends from the East, the North, the West, and the South. We're all looking at various parts of the country. Rachel M. Bond. Dr. Bond is System Director, Women's Heart Health, Dignity Health in Arizona, Assistant Professor, Department of Internal Medicine, Creighton University. The Princess Brewer. Dr. Brewer is an expert in community-based research and outreach. She's Assistant Professor of Medicine, Department of Cardiovascular Medicine, Division of Preventive Cardiology, the Center for Health Equity and Community Engagement Research at the Mayo Clinic. Mashio Forrestal, who is not yet a physician. She's one of my students here at Tulane, and she works actively with us in our Healthy Heart Community Prevention Project, and she can tell you about some of her passion related to community intervention. She's also published with me on hypertension. And Alana Morris, who is Associate Professor of Medicine, Division of Cardiology, Director of Heart Failure Research at Emory University, where I had been for several years after Katrina. And I know Alana because she is interested not only in heart failure as a disease, but an area where the disparities are real and need to be addressed. So let's get started. First question. I'm going to ask it to you, Rachel, and then Mashley, get ready. Do you think there really is a tsunami? Am I correct? Do we expect that there's going to be an increase in cardiometabolic diseases in the near future?
Absolutely. First and foremost, thank you, Dr. Ferdinand, for the opportunity to speak here today. I just wanted to address that. But to answer your question, 100% there's a tsunami. And I can say that we're seeing these effects even now in the year 2022. These effects are more so magnified, most probably because of this pandemic that we're also undergoing, which is COVID-19. But data is showing that more and more people, communities of color, are having rising rates of preventable conditions, high blood pressure, diabetes, high cholesterol. And even for myself as a specialist that focuses on women's cardiovascular care, we're seeing that more and more women, particularly at younger and younger ages, specifically in women of color, are having rising rates of, again, these very preventable risk factors such as high blood pressure, diabetes, and cholesterol. So I anticipate that unless we do something right now, we're going to see that this trajectory continues on, and it's going to happen at younger and younger stages of our life.
Mashley, you're not yet a physician, you're a physician in training. What do you think? You really agree that there's going to be a tsunami coming?
Unfortunately, unless we see serious structural change in the way we deliver healthcare here in the United States, I think that we will not be able to prevent the tsunami. And I say that because in nature, when a tsunami takes place, usually what's happening is that there is a foundation problem under a body of water, a structural shift that's happening that's creating chaos on the surface and develops this characteristic destructive wave that we know to be a tsunami. And so similarly in healthcare, there are structural issues at every level of healthcare delivery that have existed for decades that make this tsunami at this point in time inevitable. In time, I think we will be able to prevent some parts of the wave, but as of now, it's in our best interest as a general public, but especially as trainees and clinicians to prepare ourselves to take care of a lot more people with hypertension and diabetes.
Well, I think both of you have articulated very well the concept that cardiometabolic risk and cardiovascular disease not only may increase, but probably will increase significantly with these cardiovascular risks. The Princess, you study the community and you are looking at these risk factors. Do you also agree in this upcoming tsunami? And then without me prompting, Alana, you're at the terminal end, you're seeing heart failure, and I've seen data that even heart failure as a terminal disease is going to increase. So after the Princess gives her views, perhaps you can tell us what you think is going to happen with heart failure going forward.
Yes, thank you again, Dr. Ferdinand, for this opportunity. And I too am anticipating the tsunami, and I'm seeing it head on, in the community, boots on the ground, with the African American community. Many are saying that they just have so many competing demands from the pandemic that they really have not been able to focus on their own health, including their cardiovascular risk factors. And we're also seeing that more are being diagnosed, as Rachel pointed out as well within our research. We're seeing that, wow, many people are having, uncontrolled hypertension who didn't have a formal, prior diagnosis. And also here in Minnesota, we have been, unfortunately, overwhelmed by racism and discrimination over the past 2 years, particularly after the death of Mr. George Floyd, that has even added more to our stress level here. So I definitely am anticipating a tsunami in cardiovascular.
I'm going to have Alana follow up because heart failure is a disease. It's not just a risk factor, but I've seen some data that also is going to increase not only in the near future, but for the next several years to decades. Alana, what do you think?
Yeah, I mean, I would agree with La Princess. I feel like I'm already in the tsunami and trying to get myself and my patients out. Keith, you and I both practice in the southeastern part of the United States. We've got such a high burden of traditional risk factors in this part of the country, in addition to the population aging, and we're seeing heart failure more and more and more. In particular, we're seeing it amongst Black Americans who have the highest prevalence of heart failure, the highest incidence of heart failure, meaning the highest risk of developing heart failure. And for many, many years, we've known that Black Americans' risk of developing heart failure is really more so related to these cardiometabolic risk factors like hypertension, diabetes, and obesity, even if they've never had a heart attack. So, oftentimes when patients think about preventing disease or preventing cardiovascular disease, they're very focused on a heart attack. But we have to sort of reiterate to the African American community that your risk for developing heart failure is really mediated through the high blood pressure, the diabetes, and Black women, the obesity in particular really does mediate the risk for the type of heart failure that we don't even have great treatments for. We're just starting to get good treatments for. And so people sort of understanding that these risk factors really have an impact on longevity, their ability to function at a normal level is so important.
Well, you all have spoken so eloquently about the problems that we have. What about your personal commitment? I'm going to go in the same order, unless someone feels they want to make a comment before their turn. As a Black clinician, Rachel, do you feel that you have a particular commitment to addressing some of these issues? I know you talk about Black maternal health, and we're interested in all people, regardless of race, ethnicity, socioeconomic status, or geography, but particularly as it relates to the African American community. Do you feel a certain commitment?
Absolutely. I think any of us possibly, I won't speak for those on the panel, but I would probably say that any of us understanding that we are living through a lot of these experiences ourselves or our family members have, that we do have an affinity to want to make sure that we're caring for these particular patient populations, the most vulnerable patient population. I can say personally for me, looking, going through medical school as an example, I didn't quite know before medical school that there were so many disparities when it comes to the healthcare system. But upon learning that, my interest actually developed even more so because I wanted to, as you very nicely alluded to, not just address the issue, but try to figure out how I could be part of the solution. And I think for myself, you bring up maternal health as an example. And just for those that don't quite understand the backstory behind that, where it stands in the United States, we're the only developed country that are seeing rising and rising rates of death. And we know that this is occurring most probably and most commonly from cardiovascular disease during pregnancy, but it's disproportionately affecting women of color, specifically Black women, who are dying 2 to 3 times the rate of their white female counterparts. And as Dr. Ferdinand very nicely mentioned, the sole purpose and the sole reason is those social constructs that we're seeing when it comes to race, and racism is at the core of that. So myself evolving throughout my medical field, I have had an affinity to try to change these statistics that we're seeing by advocating for my patients, making sure that we are diversifying the field of medicine, because we know data does suggest a more diverse medical field will improve outcomes as well. So I'm very fortunate through the societies that I volunteer at that we're working to those means, but more importantly, that we're also doing research specifically on these communities of color and these vulnerable patient populations to figure out how best to manage these conditions we're seeing and how best to treat them.
One of our colleagues is Dr. Larry Sperling at Emory. And one of the pillars of the initiative that he leads, Million Hearts, which is the Health and Human Service Initiative, they're now looking at these disparities as it relates to cardiovascular disease in women of color and specifically African-American women. So you're spot on that translates to an increase in cardiovascular death and disability later in life. Mashley, again, you're not a clinician, you're a medical student, you're a doctor in training, but you seem to have a passion. Do you feel a certain commitment?
Without a doubt, I feel a very strong sense of commitment to making a difference. I've often shared with many that my chief why and my primary reason to keep going on the really hard days is remembering the fact that one day I'll be able to take the knowledge that I've gained and equip the members of my community with the knowledge that they need to take control of their health. And being that it's Black History Month, but even outside of Black History Month, I've had a lot of time to reflect on all the giants whose shoulders we stand on and the opportunities that we've been afforded that they weren't afforded. So in light of their sacrifices, in light of all the work to be done, I have a strong sense of duty to make a difference and be a positive force and a force for good.
The Princess, I can't speak for you, but I've seen your work and I know you're in the community doing research and outreach. You must have a personal sense of commitment.
Yeah, so my personal why is really my upbringing in the African American church, the Black church, and seeing so many people dying prematurely, from uncontrolled heart disease risk factors. I mean, and these people were like family to me, and they helped to raise me. And I have carried that with me throughout my journey towards a career in medicine, with the goal of going back to those communities to save those same lives. So others won't have the experience that I had of seeing so many people dying early. And similar to Rachel, throughout medical school, my eyes were open to the magnitude of health disparities that are affecting the African American community, and how so many people are just being labeled as the frequent flyers, or the people who are just not compliant with medications, and not really looking at the reasons why these are happening. So as you mentioned, Dr. Ferdinand, the social determinants of health, or social drivers or influences of health. So I wanted to equip myself to be able to develop real, genuine, authentic solutions with community members. So not just telling them what they need, but really, I guess, joining forces with them and not having them take a back seat while I go along this ride, but have them come up with the solutions jointly with me to benefit the community.
You know, the Princess, I have a follow-up question about non-Black or physicians who don't identify as Black, their commitment. But I will tell you, there's a recent report, and it's in a peer-reviewed literature looking at electronic health records, and the words such as non-compliant, angry, difficult to treat, it's been found in electronic records, and unfortunately disproportionately in Black patients. I think we as clinicians have a responsibility to partner with our patients and share decision-making. So it's not a matter of compliance, it's a matter of together what we can do to increase adherence and improve cardiovascular risk. But these data are available, and I would suggest all of us search it. I don't have the citation right in front of me, but it does show that these words that you mentioned, the difficult patient, the non-compliant patient, are used somewhat inappropriately. Perhaps we didn't take time to sit with that person in a culturally appropriate, literacy appropriate manner and talk to him or her about their condition.
Yep,
Alana, I know you're committed. What's the source of your passion?
Well, I mean, I think like many of you growing up as a Black American, I've had many losses, premature losses in my family as well as friends. Certainly as I get older and get into midlife, I suppose, I'm now seeing close friends and loved ones develop these risk factors, which are not solely related to socioeconomic status or lack of education, which is also, I think, something that highlights the complexity of these issues. La Princess mentioned stress and the role of stress. And this really came to the forefront for me during the pandemic. I think when many of us were seeing, just horrific images of the murder of George Floyd or the murder of Ahmaud Arbery. And then I had friends and family members calling me to tell me their blood pressure was up and they didn't know what to do. And you just sort of saw the true effects of stress that occur in our community. I think, yesterday, many of us were reeling from learning from the loss of Dr. Paul Farmer, who was one of the first people at Harvard Medical School my first year who introduced me to the concept of health disparities in sort of an academic way and really put terminology to all of the things that I had seen during my childhood and during my college years in New Orleans, and really understanding how inequities develop and how we put certain resources in certain communities and really keep resources out of other communities. And I think he was one of the first people who really impressed upon me this obligation as a physician to not just be at the bedside with patients, but to really think more broadly about how I could use my passion, my talents to really change the world. Certainly, to even have been near him and to experienced, some of the things that he taught were just so inspiring for me. But I think really trying to make a large difference, a difference on a national or a global scale was really something that he inspired me and so many others to do.
Well, that's beautiful. And actually, we know that a physician or a clinician, whether it be a nurse practitioner, physician's assistant, or pharmacist, you don't have to self-identify as being Black to see that these problems are real. This is not social science. We're talking about life itself. Mash, let me ask you, you're at Tulane, and it is predominantly a white institution. It sits in a majority-minority city since founded in 1698. 1718 incorporated. It's one of the oldest cities in North America. I always say, I'm from here, so I can say this. The French founded it, but they didn't build it. It was built by African enslaved people, and free persons of color from the Caribbean have always been a huge part of New Orleans. What about physicians, clinicians, students who don't self-identify as Black? Can they help or hinder this struggle?
So I love this question because I think the answer is that they can do either. On the one hand, they can hinder the movement by centering themselves in the work or failing to take inventory to measure progress. Because at that point, it quickly becomes an academic exercise and a CV builder more than it is about improving health outcomes for Black people. On the other hand, we really need their help because the 5% of us trainees, Black trainees and clinicians cannot carry this load on our own. So we need healthcare providers from diverse backgrounds to help the movement go forward. And I would argue that healthcare providers as a whole all have a role to play in the drive towards equity.
Rachel, I've actually presented at one of your programs in Arizona, and many of your faculty who address these issues clearly would not self-identify as Black. So what do you think is the position of physicians who are not necessarily from these communities in terms of either helping or hindering?
Yeah, I mean, I would say that they do help, and their actual input is greatly needed, and it's more importantly, desperately needed. Reason being is that to place the burden solely on those of that coming from that underrepresented minority, one, it's not effective because there will be burnout within amongst ourselves. But beyond that, we know that allyship is really the key to really talking about diversity and getting it to the forefront. So that's where physicians or clinicians of other races, other genders, other sexes, other ethnicities really should be taking the lead in this conversation and making sure that we're all seated at the table for the core really goal, which is again to diversify our field, but more importantly, highlight the inequities that we're seeing. Allyship leads to you more likely being able to look at your own implicit biases, your possibly conscious biases as well that you go through on a day-to-day basis. And this is something that I'm very fortunate to work with a series of clinicians within my own health system that are really taking this very seriously. They look within themselves on how they're treating patients, and they actually have changed drastically the way that they care for patients, be it gender, race, or ethnicity. So I do believe that it's important that we have those of other races, other sexes, other genders, and other ethnicities to have a seat at the table, because again, that's where that allyship is going to lead to bringing this discrimination that we're encountering to the forefront.
The Princess, I know you're carrying heavy burden working in your community and doing research and outreach. Do you think that others who don't self-identify as an underrepresented minority provider can assist in the struggle?
So yes, I feel that they can help us, but I agree with Mashley that we have to be careful that they do not hinder progress. My community members know that I'm very overprotective of them when it comes to research. And when investigators approach me and say, you know what, I want to work with the African-American community, I want to kind of help to fight these health disparities, I always ask, so why? And how is what is your goal, the long-term goal? So we don't want to just go in and do surveys and take data from this community that's already had so much taken away from them and then not give anything back to them. So I'm very, very overprotective in that sense. but I don't feel that you have to be from the Black community to actually achieve change. So I make that very clear early on when I'm collaborating. And then to speak from, and that's the community sense, but from the clinical standpoint, I do feel that our partners and colleagues can join forces with us in fighting health disparities towards health equity by having more of a social, cultural lens on care and really getting to know their patients and what influences their health and their abilities to maintain a healthy lifestyle. Again, going back to those social determinants of health. And we also know that from Dr. Lisa Cooper's work that, Black patients do prefer Black physicians, but it's not necessarily because of them providing better care. It's just that they feel that Black physicians listen more and they feel more respected from these individuals. So that's a lesson learned for our other colleagues, that you really need to listen to your patients and what their primary concerns are. So I don't think you have to be Black to do that.
Alana, you're over at Emory. What do you think? Do you think others who don't self-identify as Black can help or hinder?
I agree. I think that both certainly can be true. I certainly think that others who don't self-identify as Black can certainly hinder. We could also say that people who self-identify as Black could also hinder. So I don't think that we should ever see change or the movement towards equity as something that is only for Black people or only for those who identify as Hispanic or only for those who identify as LGBTQIA. If we look at any movement throughout the history of our country where we've been trying to achieve equity, whether that was the civil rights movement, Black Lives Matter, we've always had allies. And I think that has to be true, because when we look at where power is concentrated in this country, it is typically not amongst Black individuals, whether it's political power, whether it's leadership positions within academia, pharma, other economic sectors. It would be, I think, impossible for us to do this on our own. I think certainly Black people have always brought a significant amount of passion, as we do on this panel, because we are often the ones impacted directly by inequities and impacted directly by racism. But I also think that in order for us to really get things done, having powerful people who may not necessarily be in our in-group, we know that oftentimes power is the way to get change. And so having people as part of this movement who are deans of universities and division directors and chiefs of departments of medicine around the country, this is the way that we make this happen. And oftentimes those individuals, at least as we see now, are not Black. So I think we have to have allies across all race ethnic groups to make this happen.
So I'm going to go to the questions. They're starting to roll in, and feel free just to speak up. If we interrupt each other, that's okay. We're all friends. Question number one: is race a social determinant of health, or is it racism? If so, shouldn't we use the nomenclature change as we write narratives in our scientific papers? Well, let me ask it another way. Should we just stop talking about race? Don't use Black, white, Hispanic. Just don't even use those terms. Just talk about patients. Anyone?
Well, I'm going to play devil's advocate for a second. I'm going to say that I think if we really want to bring everybody to the table, for certain individuals, whether it's right or wrong, talking directly about racism turns people off. It does. Many people don't want to hear that they're racist. They don't want to believe that about themselves. And I do think that there's a difference between explicit racism and implicit bias, right? I think that many of us, because of the images that we've seen on TV, because of what we've read and learned over many, many generations, we have implicit biases related to dark skin or African ancestry or all of these factors. And I think that many of our colleagues, by doing things like the implicit association test, have had their biases made aware to them, but I don't know that that's the same thing as racism. And so I think in order to continue this conversation in a constructive way, to again, really try to get as many people at the table as possible, starting the conversation with "you're racist" is going to turn a lot of people away. And I'm not sure that that's going to accomplish the goal that we want to accomplish. So that's just my 2 cents. But
I agree with you. The reason that I wanted to do this particular program, even with the provocative title about race, was to reveal that, first of all, these disparities are real, that it's a burden on our healthcare system. It causes death and disability, and we need to address it. But it's not about name calling or trying to shame someone or make someone feel bad. And that's often a misinterpretation when we talk about these particular issues. Anyone else wants to answer the question about using the term racism in nomenclature?
I mean, I think you highlighted it very nicely that race is really a social construct. And yes, racism is a part of that, but there are other aspects when we think about these social determinants of health. So I think it is important that we do identify and individualize race and ethnicity when we're doing research in particular. But I think that our thoughts about what's really triggering these disparities in care, that's what has to change. That it's, again, not the biology of it, it's not the genetics behind it, but it's more of that social construct. And perhaps that should be within the research discussion as well, where we talk about these social determinants of health. So I think that this is an opportunity for us to change the way we approach race, particularly in the United States of America.
You know, the Princess, I wrote an editorial based on some of your work, and I coined the term up South. Up South meaning that people from the Gulf South and Houston who migrate to Minneapolis were met with harsh conditions that they really didn't expect. Here's a question that directly relates to that. Can you expound on the allostatic load in African-American communities? I think they're talking about stress and its impact.
Yeah, so stress itself is a risk factor for cardiovascular disease in the allostatic load. And I'd love for my colleagues to weigh in here as well. Is also kind of the biologic threshold that then turns us over into developing cardiovascular disease. And over time, you know, with these uncontrolled risk factors, it's really a detriment to our overall health. And going back to your point about the Up South and our recent study here in Minnesota, and about race and the importance of still pointing out race is that for years, decades, here in Minnesota, we've been labeled as one of the healthiest states in our country. And we've ignored the fact that there are clear disparities amongst African Americans as far as the risk factors and cardiovascular disease. And that has downstream effects in that these communities are not receiving the resources that they need in order to be healthy, and they're marginalized. So, you know, I still think the conversation should include race. Otherwise, these groups will continue to be overlooked and forgotten.
Yeah,
Anyone else wants to discuss allostatic load?
Yeah, I was going to just say that I had an opportunity most recently to have a perspective piece in circulation with Dr. Albert, where we talked about this as it pertains more so to women and even maternal health, a coined term, superwoman schema, which really addresses the oppression, the microaggressions that women experience, the racism that women experience, and even sort of the foremothered going back to even slavery days as an example, and what that impact can have as it pertains to the sympathetic nervous system, the hypothalamus even, and that increased allostatic load. And what we see, as La Princess very nicely alluded to, is that it does lead to premature cognitive as well as cardiovascular complications. This, as a result, is why it's very important that we do take stress very seriously, especially right now during this ongoing pandemic that we're seeing, that we do see is disproportionately impacting communities of color. So stress is a risk factor, and it's a very important risk factor, probably at the very top of the list when it comes to communities of color, without a doubt.
You know, one question that came in, and it's somewhat related to that, but this is from a pediatric PA who works in a federally qualified health center. Women of color also have so many other immediate issues that they don't take the time to care for themselves. Alana, I know you work with a lot of women who have developed heart failure and diseases early on. Is that true? Is it difficult for some women to balance all of the stresses that they have in their life just to manage their heart failure, which means oftentimes coming for multiple visits and testing and 4 and 5 and 6 medications?
You know, one of the things that fascinates me, Keith, and I have this conversation with my section chief all the time, who I would consider to be an incredible ally, is that we put, again, these labels of non-adherent on women who don't show up for visits or can't complete their transplant evaluation or can't do things. And if you ask them why, it's often because they have to take care of their children. And they don't have anyone to help, or they have very few people to sort of, come in and help them fill in. And we know that for Black mothers who often are single mothers, we're more likely to be single mothers who may not have a partner because of mass incarceration, because of so many other sort of structural factors. We will label these women non-adherent and then prohibit them from getting therapies when often they're doing what most of us do as caretakers or parents or family members, which is to prioritize the people that we love. And in reality, these mothers are prioritizing their children, but in truth, they would probably do anything that we asked them to do if we were able to provide resources to assist them with implementing, because they have everything to live for, which is their children. And so it fascinates me that we often apply these labels and then exclude people from therapies that they probably would do fine with, because one of the conversations we don't have enough is about resilience in the Black community, particularly resilience amongst Black women. And we know that, for example, our faith structures, the social support that we have, we often take these lemons and make lemonade. And again, we see these labels applied to our community, but in fact, we don't do enough digging to sort of see the resilience that's there and how we can work with people to work around some of these barriers.
There's a question here, and I'm going to paraphrase, it's fairly long, but it's whether or not the modern physician is appropriately educated and equipped intellectually, morally, and resourcefully to address these racial disparities and the social determinants of health. Mashley, you're in training right now. Are you guys going to be ready? What's happening?
I think this is education we have to provide largely for ourselves. I don't know if medical education as it stands right now is equipped to teach us what we need to know to tackle these challenges head on. So as of now, we have to find out that information for ourselves. We're not ready.
I'll give you some old 60s lingo. And we actually were talking before we started. We talk about vital education and strategic education. Strategic education are those things that you do to go from point A to point B, to get the MD, to get the fellowship, to become board certified. Vital education are those things that you incorporate in your soul, in your being, to make a difference. So our conversation, I hope, is a vital educational platform, but the strategic part of it, getting the MD degree, walking across the stage, and your family is very, very happy. That's just one step in that process. And it's not going to really make you a warrior for change. It has to come from inside. It has to be vital. I have a question here, and we're going to be running out of time soon, but we still have some time. But I have a question. Any personal insights of what drove you to address these disparities? And I'm gonna go back to my young student, because I speak to her all the time, and she talks to me about how she's studying and she's in her exams, but doing the community work that she does is really something that invigorates her. Can you talk about that, your personal drive?
Yeah, so my passion for addressing health disparities in part was born when I realized that too many people that look like me started to accept long-term complications of chronic diseases as normal ways of life. So in the community that I grew up in the community that I'm a part of now, I have met 4th and 5th generation below the knee amputees because of diabetes complications. I have met people who will casually say, everybody in my family has high blood pressure. I've met people who have diabetic retinopathy, and their mother had it and their grandmother had it. And I decided that that phenomena was absolutely unacceptable. And so as a medical student, my clinical impact is really limited right now. But one thing I can do is be faithful to serve alongside community health organizations that are at the front line of providing health information to our community members and empowering them with the knowledge they need to improve their health. And recently, one of those projects with the Healthy Heart Community Prevention Project, as well as several local organizations, I've had the opportunity to volunteer with them to put on the NOLA Diabetes Project. And the NOLA Diabetes Project is an 8-week course where community members come on a weekly basis and learn about every single facet of diabetes management, be that understanding the basic physiology, to medications, to diet and exercise, and even how to have conversations with their physicians about the diagnosis. And the most fulfilling and invigorating part of this process for me has been hearing the incremental progress that they're reporting on every single week that they come back to the sessions. And because finally, it's a group of people that decided that they were going to bring the information to the community and speak their language and practically break down what good diabetes management looks like. So this is work that really, really energizes me, because I think it's grossly inadequate for us to sit in hospitals and sit in clinics and expect the community to come to us. I think it's our job to take this knowledge to the community.
Well, Mashley, really, I thank you for that. Dr. Daphne Ferdinand, who is my spouse, actually runs that program, and it has nothing to do with Tulane. It's not downtown. It's actually in the lower 9th Ward, miles away from Tulane. And elderly persons, older persons will come in and sit there for 2 hours learning about their disease process and how they can do better. But it has nothing to do with coming to the clinic or coming to see the doctor. And I thank you for your participation in that. The Princess, I know you're doing some of the same work. You think it's really important for us to go out to the community for educational interventions versus just sitting in our big academic centers and waiting for people to show up with disease?
Absolutely. And I must say, it's just so gratifying to hear Mashley talk about her experiences in the community as a medical student and how rewarding she finds this. And we need more of this in medical education. And I really advocate for this here in my own institution, and always welcome students to join me as I go out into the communities so that they can actually see how people live and listen to them again and know what their needs are, and then translate that to their clinical practice, because this makes you a better physician and well-rounded. So it's extremely important that we integrate community outreach and community engagement, not only in research, but education and our clinical practice. So Mashley, I love that you mentioned partnering with organizations. We can't do it all along in our 15-minute visits in clinic. We have to partner with community-based organizations so that we can then have these resources for our patients, because we don't know it all. The community does. So I must say that through my research, these ideas have not come from my own knowledge or any of the training that I have. Most of the innovative research has come from community ideas and actually sitting around with them and knowing what their needs and preferences are.
Here's another question. It's a really big one, but do the best you can to distill it, because we're going to be short on time. And I'm going to start with you, Alana, and then I'll go to Rachel, since you have not spoken, and we've already heard Mashley and the Princess talk about their community work. Give me some practical tips that you can share for the everyday clinician to address disparities. Alana, I'll go with you first, and then Rachel. Practical things, something that someone's listening, they got it, I'm an ally, I want to help. What can they do?
I think the first thing I would say is don't make assumptions, because there's no single race, ethnic group that is a monolith, and we're all individuals and we're all humans, even though we self-identify as what we identify as. I think as clinicians, we have to listen more and we have to ask more questions. So we shouldn't make assumptions about what our patients are willing to do, what they can afford. If they say no to a therapy, it's because they're non-adherent. And I think that's really hard in a busy clinical practice because we're all very pressed for time. But I think, again, we have to meet patients where they are, whether that's in the community or right there in that clinic visit. So for example, if I'm having a conversation with the patient about getting an ICD, a defibrillator for primary prevention, and they tell me they don't want that, I say, okay, we'll talk about it next time. You know, I listen and I might ask them why. Why do you feel like this isn't something that you're interested in? And I listen to what it is they have to say. And I understand that with the limited time that I have, I may not be able to change their mind at that moment. But I also understand that in order for me to get them to understand the importance of the recommendation, that this needs to become part of the working agenda, right? So that every time I see them, I sort of say, have you thought about it a little bit more? Let me give you a resource. Let me send you to this link, so that over time we can engage in shared decision-making, so that I can make sure that their decision is really coming from a place of knowledge as opposed to a place of fear. But in that process, I'm sort of understanding them and the reasons why they may be saying no or reluctant, or so I think that we have to, unfortunately, we have to listen more as clinicians. We have to shut up and not assume that we always know everything, and we have to listen to our patients. They have so much to teach us, as La Princess said.
One of my life experiences is I was on the Louisiana State Board of Medical Examiners for a decade and a half. I was president for many of those years. And recently I had a resident call saying that she had one of my patients in the emergency department who didn't want to be admitted, came in with chest pain, troponins were negative, so it wasn't a clear ACS, and they wanted her to sign away AMA, against medical advice. And I cautioned my young colleague that, first of all, that whole idea of signing AMA doesn't protect you. If that patient has problems, it can be pierced very easily, saying that you didn't fully explain to the person what was going on with them and why they needed to be admitted. And then secondly, how about shared decision-making, talking to her about what else she may have. She may have young children at home who, if she goes in the hospital and not having really an acute event, but just for observation, nobody takes care of her baby. And that baby can get sick, or that child doesn't get to school the next day. There's a lot that goes into someone saying, I don't want to come in the hospital. But signing AMA is not the way to go. And I think that builds on what you're saying, shared decision-making, having that conversation. Rachel, I'm gonna let you give your remarks. And I know that you have a lot of ideas. And give me your take home, your message, your final message. Now have others give their final message on what you think we need to do going forward.
Yeah, I can't emphasize enough the importance of shared decision making. I think that as clinicians, the first thing we have to do when we step into that office is actually think about our own privilege, right? So even ourselves as women of color, we have privilege in the sense that when we look even in a comparison to our patients that are also women of color, that we understand this medical condition, that the health literacy for us is very easy. So we have to think about our own privilege and somehow simplify it so our patients can understand exactly why it's important that they take their medications, why they have their follow-up exam. And perhaps we can have that conversation to understand the limitations they have as to why they're not able to do X, Y, Z. Once we do that, and as Alana very nicely said, I do think the act of stopping and listening, or as frankly as she put it, just shutting up, is such a key part of being a clinician. Because once we stop talking amongst ourselves, we actually have an opportunity to hear our patients out. So a take-home message for me in particular is that we really want to have our patients understand that they are part of the care team. The shared decision-making, I think, is a really big part of my own practice, but it's something that we should be pushing forward and implementing earlier and earlier on, starting with our medical students as well. Because the patients, as La Princess very nicely said, a lot of times they know their bodies better than us. They're the ones that are at a very multitude of times are dictating which direction we will go in their care. So I think that as clinicians, we have to do a better job at stop talking, just listening, and hopefully by doing so, we'll incorporate the patients into the care team and the outcomes will be so much better.
That's a great take-home message. Alana, give me your take-home, and I'll follow it. The Princess, give me your take-home. And we're gonna let our budding physician give her final take-home message.
Well, I think as we've talked about, for the past hour, there's so much work to do. There's so much that we don't understand. There's so many things that we have to learn about how to integrate, these efforts into our clinical practice, and how to teach trainees, how to teach students, how to teach current faculty, because there's so many people who are even in mid-career or late career who don't understand the complexity of these problems. And so I just hope that over the next few years, more and more people will be open to the idea of learning how these problems came about, and again, sort of figuring out the best ways to address them and create solutions.
Thank you very much. The Princess, and then Mashley. And let me say, before you give your take home, those of you who want to see more in terms of resources, what these powerful young women have written to add to our understanding of medicine, there's a link that's in the chat. You will also receive an email with some of their writings. The Princess, give us a take home.
So I just want to encourage all of our viewers, listeners to remain steadfast in this fight towards health equity. And the only way we can do that is by bringing our communities in early at the forefront. And from a clinical standpoint, we must view each patient through their socio-cultural lens in order to make a true impact.
Mashley, you get the final word.
Well, right in line with what Dr. Brewer just said, community health education is just as important, if not more important, than cardiovascular health related medication that we'll ever prescribe. So my encouragement to everybody who has joined us today is to find out which organizations in your community are doing this work and ask them how you can help.
I thank you all. This has been a wonderful conversation. It's been vital education. It's not just strategic. And we've been talking about life itself and how we can make life better for all of us. Thank you all again who have been listening to us. We wanted to make sure that we address some of these issues in a very frank and open manner. As a reminder, recording of this webinar together with a list of the additional resources will be available at the CMHC website. And we will notify all viewers when they become available. Please email info@cardiometabolichealth, all one word, .org with any questions. We also would like you to recognize that there's going to be a lot of other events from CMHC, which are going to be pending, and we would like you to stay engaged. You can see at the top the great debates in cardiometabolic medicine, April 8th through 10th. There's a code there, CMHC 100, and you can hear from some of the leading experts in preventive cardiometabolic conditions. You also see that the major event in October will be in Boston, the cardiometabolic event of the year, the major meeting of the leaders and the thought leaders in the area of cardiometabolic health. And at the bottom, the big panel is a new initiative from CMHC, Foundations of Cardiometabolic Health Certification course. It's an introductory effort to review the wide range of concepts related to cardiometabolic diseases. You can get a huge 75 plus credit hours covering 9 focus areas: lifestyle, obesity, type 2 diabetes, hypertension, dyslipidemia, cardiovascular disease, chronic kidney disease, care delivery implementation, and consideration of the racial and ethnic disparities that we've heard. For more information, go to cardiometabolichealth.org. This has been a wonderful conversation. We've heard from leaders from around the country, all young women, all the future persons who are going to make a difference and perhaps turn back this tsunami. I'm Dr. Keith Ferdinand for CMHC. Thank you for joining us.